guest speaker for today. So it's my pleasure to introduce Dr. Larissa Myaskovsky. Dr. Myaskovsky received her bachelor's degree from UCLA, followed by a PhD in social psychology from the University of Pittsburgh, and then subsequently a postdoctoral fellowship in clinical epidemiology and a health services research fellowship from the VA in Pittsburgh. She is currently a professor in the Division of Nephrology at the University of New Mexico and is the director of the Center for Healthcare Equity in Kidney Disease there. Without further ado, Dr. Myaskovsky, welcome. We're very appreciative of you joining us today and look forward to your talk.
Thank you so much. And I appreciate having the opportunity to go after Dr. Watnick because her research is a perfect example of the complexity of health services research, where even if we can find the perfect medication, we still have to figure out how patients are going to get it, how healthcare systems are going to deliver it, and how we're going to price it in a way that we can get it to not only those with insurance, but our most vulnerable patients that may not have insurance. So I really appreciated being able to listen into that talk because I think it's a perfect example of the kind of research that I try to do. So I'm going to try to share my screen. I hope that works. Okay, you got to see everything. Are you seeing the slides now?
Yes, it looks great.
Great, thank you. So I'm going to talk specifically to you about enhancing equity in kidney transplantation. And I changed the title a little bit to also include some work where we've now expanded to focus on kidney health services in general. So for my presentation today, I'll briefly review the various points at which disparities occur in transplantation, and I'll describe our team's previous kidney transplant studies, as well as ongoing work that CHECD is doing. So first, a little overview of kidney transplant disparities and the various mechanisms hypothesized to underlie those disparities. This graph is based on OPTN SRTR data and demonstrates the rate of people being added to the wait list every year compared with the number of transplants completed. I'm just going to try to hide. Okay. And what you can see is a very concrete example of the well-established economic theory of supply and demand, where the demand for transplant continues to outstrip the supply year over year. As such, we know from social science, whenever you have an imbalance of supply and demand, not only can costs increase, but it presents a situation where inequity can occur. And unfortunately, whenever decisions about healthcare and health access are made and ambiguity exists, health disparities tend to follow. For kidney transplantation, the effective disparities may be found and studied across the whole transplant trajectory. So we know disparities exist in rates of kidney failure, in referral for kidney transplantation, in completing the kidney transplant evaluation process, and when patients are put on the wait list, in time on the wait list, in rates of DDKT or deceased donor versus living donor kidney transplant, and in post-transplant outcomes and adherence. So we know that disparities in referral for kidney transplantation have been studied for quite a while, and resources as far back as the 80s and 90s have demonstrated that minority group members are perceived by clinicians to be less interested in kidney transplant. They are often found to be less likely to be referred for transplant in every region of the US. They're less medically appropriate, found to be less medically appropriate in studies where medical experts are given a scenario. And we've also found that physicians believe that minority group members are less likely to prefer kidney transplants, and so therefore are less likely to refer them. When it comes to disparities in the transplant evaluation process, we know that minority group members take longer to complete the evaluation. And we often see in every minority group, they're often less likely to be preemptively listed for transplant. Even after listing, we find that racial minorities wait longer, This is data from USRDS comparing white, African American, American Indian, and Asians. But we find the same to be true for Hispanic patients waiting longer for a kidney transplant than non-Hispanic. Minorities are also less likely to get deceased donor kidney transplant, and you could see that along this line of whites compared to Black, American Indian. They are kind of overlapping with the other populations, and we have Asians there slightly above. We also see they're less likely to get living donor kidney transplantation. So that's the same type of graph where you see whites having higher rates and African Americans having lower rates, American Indian, Alaska Native, Asians, and Native Hawaiian Pacific Islanders all along the bottom. So since I moved to New Mexico and am now in a region that is quite different from Pittsburgh, where we have a lot of areas that are not just rural, but they're considered to be almost frontier-like in how far patients are from getting care. An important area that we've noticed, or that I've noticed since coming here, is that geographic disparities really tend to magnify what we see in race and ethnicity disparities. So exploring the geography of disparities entails not only looking at pockets of disparities across the country geographically, but also examining people's locations or the rurality of their location to examine how those factors contribute to disparities as well. And data show that there are actually significant and worsening geographic disparities in access to kidney transplantation, wait lists, and to kidney transplant across the US and donor service areas. So geographic differences in allocation procedures may yield diverging outcomes and experiences in different locations for otherwise similar candidates, even across similar race groups. So they really do magnify the effects. And because, and here's a graph from the 2010 US Census, and it shows America's kaleidoscope, counties where minorities are overrepresented. And because Hispanic and African American populations tend to be concentrated in highly populated OPO regions with limited organ availability, and they tend to be concentrated in areas with higher rates of poverty and more prevalent end-stage kidney disease factors, geography continues to compound racial and ethnic disparities in kidney transplantation. So this map of counties where minorities are overrepresented shows the different colors corresponding to different racial and ethnic groups. And now I want you to keep this map in mind, where our team created a map of median wait times by region. So this was created by our team at CheckD with data from the USRDS. And what we show here is that the color code is that of longest waiting time, and that's dark red, to shortest waiting time, which is dark green. And as you can see, the longer waiting time states that you can kind of capture along the bottom and a little bit in the northeast overlap with that previous map I showed you. Let's see if we can go back. That same kind of overrepresentation of the minority groups also mirrors that higher median waiting times across the country. So that's just an overview of kind of what we're looking at and the landscape, pardon the pun, of disparities that exist in our country. Now we're going to think about the social determinants of health and conceptual models of kidney transplant disparities that inform the kinds of interventions that we focus on at the healthcare system level. As you may have heard, social determinants of health matter. And this model, published by the World Health Organization in 2010, is really a very thorough model that depicts different forms of relationships of social determinants of health. So we think about the socioeconomic and political context, such as governance, macroeconomic policies, social policies, public policy, culture, and societal values. And those are considered structural determinants of health social determinants of health at the structural level. So things like socioeconomic position, social class, education, occupation are captured in the model here. However, there's also this more micro focus, these intermediary determinants of health that focus on things like material circumstances, living and working conditions, food availability, behaviors and biological factors, psychosocial factors, and then looking at these various arrows showing the relationship with how then patients interact with the healthcare system and its overall impact on health equity and well-being. And this is a pretty complex model, but it really does capture a lot of the variables we try to incorporate in the work that we do at our center. So, you know, right now, social determinants of health are very much in the media, and I know the ASN and AST and other organizations have taken a really strong stance, and I really respect and appreciate that they're doing that right now in the last few years. And certainly our newest crop of early career faculty fellows and residents and students have really been at the forefront of advocating for their patients. As a social and behavioral scientist, I'm thrilled that the medical community is taking these things very seriously, but it wasn't always so. And the importance of these factors really came to light really in the early 2000s, where two reports that were released by the Institute of Medicine, one called Unequal Treatment and the other Crossing the Quality Chasm, really shined a light on these issues and pointed to the work that social behavioral scientists have been doing and how it can be incorporated to think about how patients of different race, minority, and other vulnerable populations have unequal treatment and unequal access to care, and certainly different qualities of care that is delivered to them. So, and the main point of this, and of course the previous graph that I showed you, is that these relationships are complex, and focusing on interventions to address them is a really complex issue that I tried to pare down with a kind of more simplified model where we try to conceptualize disparities in health and healthcare, where we think about this as patient, provider, and healthcare system variables along the left here. We look at environmental factors like geography, poverty, racial segregation, and social and cultural norms. And we look at how all of these variables, maybe not all of the studies all the time, influence healthcare disparities. We think about things like processes of care, and we operationalize different processes of care and structures of care, and then look ultimately at how they influence health disparities, like medical complications, mortality, functional status, and quality of life. For transplant, our overall conceptual model is we want to look at how race is involved with disparities. But since we know that it really isn't race that's responsible for the disparities, we know it's all these other variables, social determinants of health and environment, we like to see how race actually serves as often as a proxy, race, ethnicity, for psychosocial characteristics, cultural factors, transplant knowledge. We control for various demographic and health characteristics. We look at the relationship of willingness to accept or ask for a volunteer, disparities in completing evaluation, health-related quality of life, and then ultimately how those relationships lead to disparities. And that's just an example of the kinds of variables we assess. This is based on the patient, but we look at similar kinds of variables when we think about operationalizing variables associated potentially with the provider, like their years of training and experience and specialty, and at the healthcare system, the way that they're funded, their overall infrastructure, their organizational practices, and a lot of the things that our previous speaker talked to, the decisions that influence how they take care of that individual patient, even down to the level of the medication that they prescribe and the format that the medication is delivered. So some of our early studies focused on observing kidney transplant disparities and trying to understand some of the variables, basically validating or finding data that refutes some of the variables that we were assessing. So our early overall program of research really focused on looking at social determinants of health and how they're related to time to wait listing, living versus deceased donor kidney transplant, quality of life, and adherence. One of the first studies we did was NIHD funded at UPMC. Our sample were all patients undergoing evaluation at UPMC. We assessed patients at time 1 at their initial clinic evaluation. We measured things like cultural, psychosocial, and transplant knowledge factors in the patient. We controlled for demographics. We followed those patients longitudinally via their medical records until they were waitlisted at time 2. And then we conducted a second interview with those patients. We assessed their quality of life. And then we followed them again until they were transplanted to assess their kidney transplant status. So rather than a cross-sectional analysis of patients at variable time points, we recruited these patients and followed them throughout the course of the study, following how long it took them to get waitlisted, how long it took them to get transplanted. Then we looked at the type of transplant they received, as well as their adherence and quality of life post-transplant. And we actually, even though the study funding ended in 2014, we followed them in their medical records till 2018. And a recent study, we even went back and looked at them all the way through 2020. So overall, though, what we found is that reflecting national data, as we expected, we found race disparities, and this is basically Black-white comparisons. We found those disparities in our transplant center at UPMC as well. For predictors of waitlisting, we found, in addition to the majority of demographic and medical factors that you would expect, predictors of shorter time to wait listing included low or more comorbidity, no dialysis. We didn't find support for cultural factors, but we did find support for psychosocial support and transplant knowledge. In addition, we found slight disparities in the rate of DDKT, or deceased donor kidney transplant, for white versus African-American patients, and of course for living donor kidney transplant for white versus African-American patients. And in terms of predictors of time to transplant, we found when we looked at any transplant, were there predictors? We found a variety of demographics. We also, whether the transplant occurred before or after CAS obviously was important. And then we found some cultural and psychosocial factors were important as well. So lower religiosity, higher social support, and more learning activities among the patients predicted lower time to transplant. And then we found different predictors when it came to deceased and living donor kidney transplantation. And those are the ones we present for you there. These papers have been recently published. Your own Dr. Ng was first author in our time to wait listing paper. It's something that we completed while she was still here at UNM. And then a subsequent paper completed along with my undergraduate and graduate students focusing on social determinants of health was published in CJSON earlier this year. And those reflect the data that I just presented to you. Now that data, as I mentioned, had a lot of interesting information that we collected. So we're also looking at things like non-adherence. That was a paper that Dr. Ng also headed, and that was recently, actually it's in press with Transplantation Direct right now. We also, the study that I mentioned where we're looking at the data through 2020, we looked at the combined roles of race, ethnicity, and substance use in predicting likelihood of kidney transplantation. And we unfortunately found support for that double jeopardy finding that's often been found in other areas. This is now empirical longitudinal data demonstrating that double jeopardy exists in kidney transplantation as well. We're also going to be looking at patient-reported outcomes, and that's a paper that that actually is on my desk to finalize and the last revisions and submit for peer review. And then we're looking at social determinants of health, assessed how they predict changes in quality of life pre to post-transplant. And that was pretty much our oldest study. And we did similar work at the VA when I was still there in Pittsburgh. Again, it was patients undergoing evaluation at the 4 national transplant centers. At the time we did this study, there were only 4, now there's actually 7. We did the same kind of evaluation where we recruited patients at their initial clinic evaluation in Oregon, in Iowa, in Pittsburgh, and where am I missing? In Nashville. Those were the 4 sites that did kidney transplant at the time. And we assessed those measures again. We followed them via medical record and assessed waitlisting and status as well in terms of their final outcome. So we looked at time to waitlisting, type of transplant received. Because we had shorter funding time with this study, we weren't able to follow the patients post-transplant to look at their adherence and quality of life. But what was interesting is that we didn't find those same kind of race disparities in time to waitlisting between African Americans and whites in the VA as we did in our non-VA setting. And we did find some modest differences in DDKT, but not the way you expect, in that actually all minority groups were more likely to receive DDKT more quickly than white patients, including African American, Hispanic American, and other minority groups. We did, however, find support for those race disparities as expected in the national population for living donor kidney transplantation, where when whites were the reference group, African Americans were less likely and other minorities were less likely to get to living donor kidney transplant than whites. But in this case, Hispanics were not, but that actually was not a statistically significant difference. And that research is a little bit older. It's been published in Transplantation 2017 and 2019. But the important thing is, this was the first kind of clue to us that there's something about how the healthcare system evaluates patients for transplant and brings them through the evaluation process that was different in the VA than non-VA settings, and gave us some clues about perhaps there's something at the healthcare system level that we can do to intervene and kind of shrink or reduce those disparities at least. These are some predictors that we found where age, comorbidity, insurance, and center location and depression predicted time to waitlisting. And then in addition to demographic and medical factors, knowledge and learning predicted type of transplant. So in conclusion from this early work, we found that the VA National Kidney Program does not exhibit all the racial disparities that are found in national data and we found in UPMC as well. But we did find that social determinants of health do predict waitlisting and type of transplant received regardless of type of transplant center, VA versus non-VA. So whereas structural changes may help, we know from the data that social determinants of health affect patient outcome regardless of the overall healthcare system infrastructure. And so we cannot ignore those. If you look at social determinants of health as risk factors, those are not risk factors you can ignore simply by changing the healthcare system. It needs to be a multi-level type of intervention. But we did conclude that the VA approach to kidney transplant evaluation can surmount disparities. And so when we think about interventions, we really do need to focus on center level interventions. And that's what brought us into thinking about structural interventions and really community-based research to reduce disparities. So what I'm going to do now is kind of shift over to the work that we're focusing on, that focuses on healthcare system level interventions, as well as partnerships between the healthcare system and communities who are most vulnerable to disparities. And in New Mexico, that is our Hispanic American population, as well as our American Indian, Pueblos, and partners throughout the area. So in our next set of slides, I'm going to give you an overview of the different types of projects we've been doing and the early data that we have, because a lot of these projects are just in their startup phases. An important thing to think about and consider when implementing interventions to reduce disparities in clinical care is this formula for success when it comes to implementation. So not only do you need effective innovations that can aid, aid our interventions in care, but you need effective implementation. So when you're studying interventions at the healthcare system level, at the same time that you want to see does it work or not, you need to think about what are the secret ingredients that make your special sauce to make it work. So we have the effective implementation. We need to look at those enabling contexts, and that has to do with the patient, provider, and healthcare system. What are the contexts? What is it about the patient? What is it about the provider? And the kind of the clinical context that makes it most effective. And all of these have kind of a multiplicative effect to garner socially significant outcomes and help our patients. And this is a great model that I borrowed from the National Implementation Research Network at UNC Chapel Hill. And this means that if, as you remember from multiplication, if 0 is your value in any of these areas, your effect for socially significant outcomes will be 0 as well. So when thinking about these kinds of healthcare level interventions for implementation, all of these things need to be paid attention to, accounted for, and examined. And so the work is complex, and it really does take a multidisciplinary team thinking about these at these different levels of analysis and coming together to solve the problems that our patients face in a socially significant way to make an impact on a large scale. So the first study that we talked about that we are now analyzing was also NIHD funded. This was a study called Reducing Disparities in Evaluation, Increasing Living Donor Kidney Transplantation. It was also done at UPMC. We just finished collecting the data in 2020, and it focused on an intervention called Fast Track. So this is a kind of concierge-based approach to transplant evaluation. We know that kidney transplantation process is really lengthy, demanding, and time-consuming. Obviously, I don't need to tell this to all of you. You take care of these patients, and you know that they have to do a long cookbook list of tests in order to complete those tests, and often they have to be responsible on their own to deliver that information or make sure that that information gets to the transplant team to be presented at conference. And we wanted, at UPMC, we wanted to use models that we knew were available in some centers like the Mayo Clinic to kind of fast track that system. And sorry about that, little distraction there. We wanted to use that approach and think about, can we change the way we evaluate transplant using Fast Track? And so I worked with our surgical team, our hospital administration team, and leadership within UPMC to really focus on all the aspects of the evaluation process and change it from the system that used to take patients a year, 2 years, even 3 years to complete. And we wanted to concentrate it down to a couple of days to a couple of weeks to complete it. And so what we did was instituted Fast Track. And basically, as I mentioned, it's a concierge-based approach to coordinating the evaluation appointments. We increased the FTE for a scheduler at our transplant clinic. So they not only scheduled same-day appointments, but they made sure to take care of all the other appointments that patients need when they're being evaluated for transplant. And that was done for all of our cohort of patients starting in about 2013. Actually, sorry, 2014. And what happened was we were funded by NIHD to do this for all the patients because the transplant team said, this is really great. We can't randomly assign patients to not get this because Larissa, you did a good job convincing us that the evaluation process takes too long and we need to fix it. So what I thought was going to be a random assignment to Fast Track had to become a comparison with our matched historical controls. Luckily, if you noticed by the years, my previous study that was funded by NIHD allowed me to collect all this data on all of our patients who were evaluated for 5 years before we implemented Fast Track at UPMC, and therefore they became our matched historical controls for the Fast Track evaluation. At the same time, because we were interested in increasing living donor kidney transplantation, we used Dr. Ebony Boulware's program called Talking About Living Donor Kidney Transplant, which is actually a booklet and video that it was based on focus groups that was developed to educate kidney failure patients about all the modes of end organ treatment. So dialysis, distinction between hemo and peritoneal dialysis, living and deceased donor kidney transplantation. And the approach was to randomly assign them to talk so that while everyone is getting Fast Track evaluation, we were going to test the efficacy of the talk intervention at the same time. At the same time, realizing that this required clinical set-asides, it required an extra FTE for a scheduler. What we also included in this study was a cost-effectiveness component, and I worked with my colleagues, who I continue to work with, in the School of Public Health and Public Policy, where they focused specifically on the cost-effectiveness analysis component of this study. And as I mentioned, that data, we are looking at not only time to wait listing and type of transplant received, but also the cost of Fast Track and whether the cost of the additional staff needed to run Fast Track, the benefits of it outweigh the costs of doing it. And as I mentioned, the study is completed. Our data analysis is currently in progress, as is our manuscripts. The protocol paper for this is out there. Another thing that we did, because UPMC had several sites where they do transplant evaluation, they incorporated Fast Track in different ways based on what those sites were able to do. And what we were able to do in our analyses, actually those analyses are still ongoing, is do a kind of dose response when it comes to Fast Track. We have the highest level of Fast Track at one site and then different levels of Fast Track implementation at two other sites. And so we can almost compare how much of this Fast Track system level implementation is needed to get a desired effect of more people going through the evaluation more quickly. And that is a really important cost effectiveness analysis piece, because not all transplant centers have the same resources and facilities. And some may need this kind of approach where we can't do all of it, but if we do just this much, we can get a huge benefit to our patients. And so we're really excited about being able to do that kind of analysis as well, because I think we all know basically deep down, and we know from data as well, getting more patients evaluated, getting more patients transplanted more quickly, not only benefits them, their well-being, their quality of life outcome, but also is less costly to the healthcare system, both for Medicare as well as insurance, because it's much less costly to transplant a patient and pay for their post-transplant immunosuppression. Finally, they acknowledge for the rest of their life, not just for 3 years after transplant, but for the rest of their life. Even that's more cost effective than maintaining this large population we have on dialysis. So hopefully this study helps us in the next step of how to get more patients through that evaluation process. At the same time, once I moved to UNM, a big thing that my chair and chief, Mark Unruh, who many of you know is a nephrologist, he was like, well, now, Larissa, you're in a center that is a safety net, state-funded hospital. We certainly don't have the resources of a Mayo Clinic. We don't even have all the fancy resources that UPMC has, but we've got to take care of all of our vulnerable patients and try to give them the same quality of care as they would get anywhere else. So he basically challenged me, what can we do here at an institution like UNM where we can't possibly afford all the bells and whistles of fast track? And if we can, is there something we can do to help improve those patients going through evaluation as well? So again, what we're doing is recruiting patients undergoing kidney transplant evaluation. Mind you, this was a study funded by the NIHD. We got the funding notification July, in the middle of our COVID pandemic. And so as a result, everything we had proposed and planned in the project, even though it was funded, we had to change because we couldn't, for a while their patients weren't being evaluated for transplant at all. And then when they were, we had to figure out how to do everything via Zoom. So while this study was funded in 2020, we are only now, next month, going to start recruiting our first set of patients. And so what we decided here is, rather than just looking at fast track versus no fast track, we're going to do a comparative effectiveness pragmatic trial where we compare fast track versus peer navigators. So fast track is the same. We worked with the different clinics, with the hospital administration to do these clinical set-asides across the different service lines. But we also wanted to explore more cost-effective approaches to improve the kidney transplant evaluation process. We got inspiration from the work that I did at the VA, as well as from colleagues at Case Western in the form of peer navigators. Some of you may be familiar with Ash Siegel's work, where he's looked at bringing peer navigators into dialysis clinics to encourage more patients to consider transplant and getting evaluated for transplant. In most of those cases, it was really to have those patients consider just getting referred to transplant and moving in the direction of the evaluation. Here, what we're doing is getting former transplant recipients to, and we're partnering them with patients once they've already been referred to the eval clinic and are recruited for our study. So in this case, we are randomly assigning patients to fast track versus peer navigator. We're also training our peer navigators, and these are patients. We have 2 patients that are of Hispanic descent. We have 2 patients that are white and 1 that is half American Indian. So we are trying to match our peer navigators to the patients. We also have patients who have experienced all kinds of transplant evaluation experiences. So we have 2 that were on that were preemptively listed, 2 that were on peritoneal dialysis, and 1 that was on hemodialysis, so that we can try to match the peer navigator with the kind of experience that the current patient is having for their end-stage renal disease treatment ahead of transplant. And in this case, what we're doing is we're also examining time to wait listing, type of transplant, and as well as we're doing a cost effectiveness analysis. But what we added to this one, and this is kind of in the traditional of social science, we thought perhaps something about the experience of fast track or peer navigators might actually affect the kind of culturally related perceptions that patients have. So in all of my previous work, I looked at things like experience of discrimination, perceived racism and trust in healthcare, and how that may have influenced patient engagement with clinical care and their outcomes. But we never thought to think until this study or to explore how might a different experience in the healthcare system influence or change patients' perceptions of racism or discrimination in the healthcare system. So what we're doing in this case is not only looking at these as predictors or risk factors, but we're also looking at these as outcomes that might change over time because of their new and different experience in the healthcare system, where there's a focus either on concierge service that is more hands-on, or on peer navigators who are basically patients who have walked in their shoes, have had the experience of dialysis and have gone through the evaluation process, and are basically probably most attuned to the kinds of questions and needs and ambivalence that patients new to the evaluation process might be experiencing. So again, for this study, we've prepared all the clinical set-asides at this point. Our peer navigators have almost completed their motivational interviewing training, and that's being headed up by a clinical psychologist who has expertise in training in motivational interviewing. And like I mentioned, we are going to be recruiting those patients hopefully starting next month. And I'm seeing that I'm running, I think I have about 15 minutes left, so I want to make sure I get through all those projects. I also want to talk to you about some work that we're doing now. This was another study that we're only now piloting at UNM. It's funded by Dialysis Clinic, Inc. And it was actually inspired by a talk that Dr. Ng gave at our East by Southwest conference when I first came to UNM in 2017. At that conference, Dr. Ng was discussing all of the complex medical treatments that patients have to undergo post-transplant, and how nephrologists have to carefully weigh the medication to treat post-transplant clinical events like newly acquired post-transplant diabetes or increases in weight due to less activity post-transplant, and the complex balance of those medications with all of their post-transplant immunosuppression. And being the only kind of behavioral scientist in the room, I thought, well, what about diet and exercise? Isn't that something that we already know has been demonstrated to be very successful in general diabetes populations? And could we not think about an approach such as this with our post-transplant patients? So that's how the Improving Healthcare Outcomes in Minority American Transplant Recipients Using Culturally Tailored Novel Technology was born. It's an early post-transplant behavioral intervention that focuses on diet and exercise. We created a standardized, culturally tailored intervention where a physical therapist and a registered dietitian, nutritionist works with the rest of the transplant team in concert to help patients engage in healthy lifestyles post-transplant. We recruit them within a day of their actual transplant surgery. So we know that from other research, transplant is an opportunity. It's a teachable moment for patients that are taking stock of their life, who are very thankful for the new gift of life they've just received, and maybe more apt to think about changing their health behaviors or at least moving in the direction of engaging in healthier behaviors. So what we do is we have a nutritionist that's a, you know, the nutritionist is standard in transplant care, but they have a lot more time with the patients that coincide with their post-transplant visit. We also added a physical therapist to the team, and the physical therapist works with the patients to first rehab them to higher activity levels, and then engage in the KDIGO guidelines for post-transplant patients and CKD patients in terms of recommended daily exercise. We have several points in the study where we track patients' activity with these. They look actually really big here, but they're actually like about this small. They get attached to the patient's thigh. They wear it for a week. They are attached with an adhesive. They wear it with for a week so we can track their activity. We track their activity at 4 time points throughout the process, and I'll show you that in a minute. And another thing that we use is the novel technology with the Twistle patient engagement platform that allows us to communicate with our intervention patients, deliver all the questionnaires, and also assess their adherence with the intervention. So this is the patient sample and their timeline. We ultimately hope to recruit 20 Hispanic, Latina, American, Indian, or white kidney transplant patients for the study. We have 15 of the 20 already recruited. And what we do here is that within, like I said, 12 to 24 hours of their surgery, we get notified by the transplant team often when they're about to be coming in, so we're ready. We recruit the patients, and then we randomly assign them to get impact or usual care. We do the baseline interview, which is those in-depth behavioral and cultural assessments to assess patients' food access, exercise access, their neighborhood, and then they get that personalized, tailored approach to both diet and exercise. And you can see by this figure, these are the 4 time points of the active PAL monitoring. The intervention itself lasts 6 months, and it follows those first weekly, then bi-weekly, and then monthly visits that they would get with the transplant team. That's where our impact interventionists meet with them as well. And then we follow them one more time at 6 months. We do an interview with both the intervention usual care group at 6 months, and then we don't interact with them again until 12 months, where we are going to assess adherence to the intervention, any kind of long-term effects. And basically the idea here is not really to look at outcomes, because it's really only a pilot study. We're just testing the feasibility of doing this study, of recruiting the patients, of being able to randomly assign them, of having those patients use those active PAL monitors and return it to us, and how well that Twistle patient engagement platform will work with engaging with our patients. And I can tell you, we've had really great support and enthusiasm from the nephrology and transplant team. And obviously we couldn't do this study without them as well. So this is another example of that really multidisciplinary partnership where we work with folks from all different kinds of areas of expertise to come together to improve the health and well-being of our patients. This is another study that we're partnering with colleagues in family and community medicine. This is the HERN Health Experience Research Network. It's a study that is using videos with patients to talk about their experience in healthcare. Now, with CheckD, we were obviously interested in something related to kidney disease or kidney transplantation. So what the study is doing at UNM is we have video recordings where we have these open-ended, in-depth interviews of patients describing their experience. And for our purposes, we're focusing on living kidney donors, describing their both positive and negative experiences with kidney donation. So not only are we using that video recorded data, to qualitatively code and assess those experiences, but then the interviews get stored and saved, and they will be freely available, obviously with the participants' permission, on the HERN network. And the HERN network makes these available online so that patients, family members who are about to experience a certain type of procedure or a certain type of therapy can see from the patient's perspective what it was like. And in this case, we thought it would be very useful for potential donors and their family members who are thinking about living kidney donation to hear about different patient experiences. And one of the great things about being able to do this study at UNM is, once again, we are listening to the voices of patients that are often underrepresented in this kind of research. So our Latinx and Hispanic population, as well as our American Indian patients, are included in these videos to get a very kind of representative and thorough sample of the patients that are most afflicted with end-stage renal disease. Another study that we're looking at is a kind of a social epidemiology study that works, that we're working on the built environment and how that influences kidney outcomes. So again, what we're looking at is how is race related to these outcomes, but here, how are those disparities and outcomes mediated or moderated by neighborhood built environment? So we are partnering with the CRIC opportunity pool, the chronic renal insufficiency cohort that many of you, I'm sure, are familiar with. And this was an NIHD funded supplement from CRIC, where we're using CRIC data, and we're also accessing Dun & Bradstreet data and other data that is actually freely available from national databases to assess neighborhood walkability, food environment, which is like food swamps and food desert, as well as residential racial segregation. And we're looking at how those social determinants of health at a larger kind of neighborhood status influences outcomes like diet, cardiometabolic health, health-related quality of life, CKD, CVD, and mortality. And these are all variables that the CRIC has already collected. We're just looking at the data that they have in new ways and pooling it with other data sources available. That's a study that just got funded this summer, and we're already working with the CRIC team to obtain the data. And then we're working with our geocoding group at UNM, along with Dun & Bradstreet, to pull that data together and then analyze that data to look at these kinds of factors. Finally, I want to discuss some research that had been going on at UNM for a long time, since 1995, and it's been funded for years from different organizations. And our CHECD Center now collaborates with the organizers of the Zuni Kidney Project. The Zuni Pueblo, unfortunately, is one of the Pueblos that has been most afflicted with ESRD, more so than other American Indian populations. And they've been struggling with high rates of diabetes, CKD, and end-stage kidney disease. And our colleague, Dr. Raj Shah, has been involved in the Zuni Kidney Project since 1995. And this is very much a community-based participatory research, where he worked with the local Zuni Pueblo to open a clinic there and serve the members of the community directly from the Pueblo. They are located very close to the IHS clinical facility, but again, this is a research facility where they have different kinds of equipment to engage in research studies right there on the Pueblo, which is about 3-hour drive from UNM. Work from this project actually helped support another project that we worked on once I got to UNM, which is the AI CRIC, so my colleagues, Mark Unruh and Dr. Raj Shah, and I collaborated to submit an NIDDK R01, partnering with the chronic renal insufficiency cohort to collect the kind of data they had been collecting for CRIC on the American Indian population, which was very much underrepresented in the overall CRIC cohort. So we called this study AI CRIC, and we partnered with NIH and with the CRIC Coordinating Center when we submitted the grant, and we are recruiting patients at the Zuni Pueblo, at First Nations Community Health Center, as well as a Phoenix NIDDK site, and then another site, obviously, in Albuquerque. And this study, again, was funded just before COVID happened. And as you may be aware, our American Indian populations and the Pueblos were most strongly afflicted by COVID, more so than a lot of other populations. And our study came to a screeching halt because of COVID, and we're just now being able to, reactivate activities. So I'm excited about this project. We're partnering with the infrastructure of the community-based research team that was already there at the Zuni Pueblo, along with partners in different parts of New Mexico as well as Arizona to capture different American Indian populations and really contribute to that overall knowledge that we have and data sources that we have, so that someday someone else can go off to the CRIC opportunity pool and use the data we collected at AI CRIC to look at these kinds of variables and look at things like food security or food insecurity and see how those contribute to CKD and renal disease outcomes as well. So I do want to give a shout out to our partners at NIHD and our partners at the Zuni Pueblo. The AI CRIC research was of such interest, it captured the attention of the director of the National Institute of Minority Health and Health Disparities, Dr. Alicio Perez-Stable, and he actually came and visited UNM. We all drove together at 6 a.m. to the Zuni Pueblo and met with the tribal elders, with the tribal council, to talk to them about kidney disease and talk to them about what is most concerning to them in their community. And we took it as an opportunity to not only listen to them and make sure we're brainstorming on projects that are key interest to them for their patients and their family members, but also we want to make sure that NIH hears about this too, because it was the first time that leadership came out to the Pueblo, and they gave us a very warm welcome. As you can see here, they did actual ceremonial dances to represent this kind of new era in partnership with NIH and UNM. And we're hoping that as more folks are vaccinated across the country, I know we're all keeping our fingers crossed for that, we can engage in more partnerships in the years to come, so that we can take care of our vulnerable patients, not only in our healthcare centers, but in the communities where they live, where it's often hard to access and come to our healthcare facility. So in conclusion, what I want to summarize is that I argue that engaging in health services research on kidney disease and kidney transplantation with multidisciplinary teams and involves patients, providers, and the healthcare system is really a strong and effective way to help deliver socially significant change for our patients. Whether it's in the clinic or in their community, we can work together to really help take care of our patients, get them better access to care. We can't just focus on trying to change the patients and trying to change their behavior. We need to change our behavior and how we deliver the care. But we've got to do that in a way that recognizes that everything costs money. We don't have endless supplies of it. And so we need to make sure we do it most effective and efficiently and do more with less, because we've all learned we have to do that. And I'm so excited that I got a chance to talk to you today, because I love talking about this work and opening the opportunity for new collaborations. I do want to thank my colleagues at UNM who are so influential in this work, as well as at UPMC, and also my CheckD team. This is a photo of us pre and post COVID. This is our first team is pictured here in front of our building. Our graduate student postdoc have gone on to their next stage of life. And this is what our team looks like now as we meet over Zoom. And we have new undergrads, graduate students, and postdocs who are energetic, excited, and really, really focused and motivated truly, deeply to make changes in their communities. So thank you for your time. I'm going to stop sharing and hope I left enough time for questions or conversation.
Thank you so much. I'm just going to read one comment from Glenda Roberts. So excellent presentation. I hope that other transplant centers will evaluate how they can implement kidney transplant fast track or some portion of it. I was on a panel this week where kidney transplant participants expressed our frustration with how long it takes to complete the transplant evaluation process. And then if Kate is still here, I'm just going to have her ask her questions. Kate, if you're available, go right ahead.
Sure. Well, I could ask a lot of questions. First, thank you. Huge body of work. I really appreciate the presentation. And I guess I have questions about different levels of how to improve the transplant process. The first one is about how adaptations to the UNOS allocation system might impact some of those patterns that you mentioned earlier in your talk about association between wait time and racial and ethnic minority populations. And then I'm also curious about whether and how you've thought about the interface with a primary nephrologist in your interventions and thoughts about the evaluation process.
So, I'm going to answer your second question first, because it's something that's near and dear to my heart. One of the really great things that my chair convinced me to move from Pittsburgh to New Mexico was that our nephrology team actually runs the transplant clinic. And he said, you're going to be able to get a lot more done with our transplant patients because the nephrologists are going to believe in what you do, and they're going to help you make it happen in a way that you won't have to convince a bunch of surgeons, So I think it made a difference. Although, our surgeons in Pittsburgh were awesome, and they were the ones who are like, yeah, we just got to do this for all of our patients. We're not going to let you do a random assignment because this is really important stuff. And so I do have to say that working with the primary nephrologist is critical to this work because you guys are the ones who really are the advocates for your patients. And a lot of the work that I've done has always involved, in fact, not even a lot, all the work I've done has always involved transplants on my core team. Yuharn has been at in almost every meeting, if I can recall, while she was here, because as a social and behavioral scientist, I can think about things on a larger scale, on an individual scale, but I'm not a clinician. And that's why it's really important to have nephrologists who are clinically interested in this area, but also have interest in the research aspect of this area, because they need to be at the table. They need to be helping us make those decisions. You guys are the ones who see your patients. You're going to tell me they're never going to do this, or they are going to do this, or you're going to be the one to tell me, don't forget that our patients get itchy. How are we going to handle that? How are we going to take care of these different kinds of issues that I would never know about since I'm not a nephrologist? It would be great if I could get trained in all this. And I did. From my career development award that I got funded, I did sit in on the nephrology fellow seminars, but I'm not trained. I wasn't trained in medical school, and I wasn't trained in medical residency. I sat in on the fellowship to kind of get an understanding of it so I can know what are the key things. But nephrologists are very critical to this work. And, you know, the more that I did in transplant research, the more I realized that we need to look at the whole continuum of care. We obviously, I don't need to, I'm preaching to the choir here, right? Earlier intervention and slowing the progression of CKD is really important. I didn't get a chance to talk to you about some of the other work that we're just like in our thinking and developing stages that we're going to be submitting for grant review, but it really does focus on provider level interventions to expand nephrology care in kind of low access settings where there might be there might not be nephrologists available. So how do we, using the ECHO model, how do we provide that kind of expertise and training to maybe non-nephrology trained physicians who are primary care providers or even nurse practitioners and community health workers? And then also we're looking at earlier CKD interventions to implement more treatments early on to slow the progression of CKD before it gets to end-stage kidney disease. And then your first question about UNOS, I believe that there is a lot of work to do there. I believe, actually, I think that's another one, Yuhan, the kidney calculator. That's a paper that you just published in Kidney 360, right? That kind of addresses that.
I think it's a little, I think Kate's question was, how does the policy change affect? And we've talked about that in the first paper in terms of, you know, getting rid of the HLA-B matching, and then putting in wait time, which only came in 2014. So that had some impact on racial disparities. But I think Kate's latest question is, you know, how does the geographic, so the latest policy is we're going to work towards getting rid of geographic disparity. So like, you know, getting rid of.
I think those were in 2019, right? Those were the latest changes that to try and address these geographic. So frankly, I think that's another thing that was unfortunately slowed down by COVID, because I feel like there was a lot of momentum in 2019 to have those in place. Those were new announcements released. I believe we were all excited and celebrating that when I believe it was June 2019 that happened, where those of us who were interested in geographic disparities saw this as a potential move forward. And I haven't followed it yet, and only because I haven't seen much about it since then, but maybe some of others on the call have been following it more closely. Frankly, my colleague, Mary Mandadu, has been on the UNOS board for a while, so I can ask her and get back to you about that, Kate, because I think that is a really important issue. It probably was put on the back burner with COVID and trying to keep our dialysis and transplant patients safe. And I think it kind of went on the back burner. Oh, good. You got the updates page. Excellent. Thank you.
Well, thank you so much to Dr. Myaskovsky for joining us this morning. Really an impressive body of work. Thanks to everyone for being here, and a reminder that next week is our pre-ASN abstract presentation session, so look forward to seeing everyone there.
Great, thank you. And also, I do want to ask if folks are interested. I've done a lot of multi-site studies, so if folks who are interested in expanding any of the work we're doing, using your center as a site for this work, I would be so thrilled to expand it in that way and help kind of open those lines of collaboration across our sites. Thanks very much.
Wonderful, thank you. All right, have a good weekend, everyone.
Thanks, bye-bye.